In this video, we're going to talk about the electrocardiogram, or the ECG, and this tells us a little bit about the electrical activity that occurs during a single heartbeat, and it allows us to look at the health of the heart. Just before we do the ECG, we'll look at the structure of the heart, and we'll look at the blood flow through the heart and some of the main structures like the chambers and the blood vessels. So if we look at a picture of the heart, we know that we're actually looking at the heart as though it was within a person. So the left-hand side of the drawing is actually the right-hand side of the heart. Now we know the heart has 4 chambers. The 2 chambers at the top are called atria, and the 2 chambers at the bottom are called ventricles. Now if we describe the right-hand side of the heart to start with, we can look at the flow of blood. So we know atria receive blood from the veins, and that blood will be under low pressure because we know veins have a large lumen and the blood is actually under a lower pressure as it enters the atria. So the main vein is called the vena cava, that supplied the right atrium with deoxygenated blood, and there's actually 2 of them. So the superior vena cava delivers deoxygenated blood under low pressure from the head and the neck region into the right atrium. We know the inferior vena cava delivers deoxygenated blood under low pressure from the thorax, the abdomen and the lower body back into the right atrium. So the right atrium will start to fill up with deoxygenated blood, and at this point the atrium is relaxed. It's under diastole, so atrial diastole, nice and relaxed. So once it fills up with blood, it increases the pressure inside the right atrium. Now at this point the AV valve would have been closed, but the higher pressure above the pressure in the ventricle beneath the atrium causes the AV valve to open. So AV means atrioventricular valve. Now about 2/3 of the blood moves through the AV valve. It kind of trickles through to start to fill up the nice relaxed ventricle. The last third of the blood in the right atrium gets squeezed down and through the open AV valve when the walls of the right atria contract. It's called atrial systole. So that allows the last of the blood to be squeezed down through the open AV valve to fill up the nice relaxed ventricle. Now the ventricle has to completely fill with blood before itself starts to contract. So we see the blood here, it starts to accumulate in the right ventricle. We know the right ventricle and also the left ventricle at the same time contract from the apex upwards. So it's an upwards contraction through the walls of the ventricles. Now as soon as the ventricles start to contract from the bottom upwards, the AV valve that separates the atrium with the ventricle closes. So this is going to close here, this valve, and that prevents the backflow of blood up into the atria. Now the closed AV valves, they don't invert because there's actually tendinous cords that prevent inversion of the AV valve. So the blood can't go back up, there's no backflow of blood into the atria. Now at this point the semilunar valve, which is the one above the ventricle in the artery that exits the ventricle, is also closed. So this would actually be closed here. So the volume of blood within the ventricle is the same. It's called the isometric volume of blood. But the space within the ventricle is actually getting smaller, and that's because the ventricle is contracting. So you've got a certain volume of blood within the ventricle. The ventricle is getting smaller and smaller because it's starting to contract from the bottom upwards, and that builds quite high pressure within the ventricle. Now we know the pressure in the right ventricle is actually going to be slightly lower than the pressure in the left ventricle. And that's because the left ventricle has a very thick cardiac muscle wall, and it has to build a higher pressure because this blood here on the left hand side has to go up through the aorta and around the systemic circulation, which is a further distance. It's a longer distance for that blood to travel. The blood from the right ventricle is actually going to get pumped up through the pulmonary arteries and go towards the lungs. And because the lungs are actually quite close to the heart, the pressure doesn't have to be quite so high to force the blood through the pulmonary circulation. Now, as the pressure builds and builds in the ventricle, the pressure behind the semilunar valve is going to be greater than the pressure in the artery the other side of the semilunar valve. So the semilunar valve opens to allow the flow of blood into the artery, whether it be the pulmonary artery or the aorta on the left hand side. Now, once that blood has gone into the artery, we know the pressure in that artery increases, and that snaps shut the semilunar valve to prevent the backflow of blood into the ventricle. So the blood will be pumped in a forwards direction through the arteries. Now, we know arteries have a very thick muscular wall. So they've got the tunica externa, which is made of collagen, and that prevents overstretching of the artery. The tunica media is very thick, smooth muscle and elastic fibers. And the thick, smooth muscle prevents any damage. It can withstand the high blood pressure. And the elastic fibers recoil to allow maintenance of that high blood pressure once the blood is passed through that point. Now, once the ventricle has finished contracting, it will then start to relax once again, and it undergoes diastole. So at this point, the atrium is relaxed and the ventricle is relaxed, and the atrium starts to fill back up with blood. The ventricle is empty of blood at this point, and the cycle continues once again. That's called the cardiac cycle. So this is the electrocardiogram. So electrocardiogram, or ECG for short. Now this shows us the electrical charge or the voltage through different parts of the heart over time. So if we look at the labels, we can see on the y-axis going up the left side is the voltage through the cardiac tissue in millivolts, and the x-axis going across the bottom is time measured in seconds. So we can look at the electrical charge through different parts of the cardiac tissue over time. Now the ECG we can actually start to annotate, and there's three parts to this graph. The first part is called the P wave, so we'll call that number 1. The second part is the QRS complex, so this very, very tall spike in millivolts. And the third one is called the T wave, so we'll label that number 3. Now, the P wave represents depolarization of the atria, and that's a consequence of the wave of depolarization spreading out from the sinoatrial node, or the SA node, across both atria, from the right atrium and over the left atrium. And this causes the atria to contract, so it results in atrial systole. So we can say here atrial depolarization. So the wave of depolarization spreads from the SAN, or the sinoatrial node, across both atria, causing them to contract. So atrial systole. So we can write that down here, atrial systole. Now, we know the wave of depolarization reaches the AVN, the atrioventricular node, at which there's a 0.1 second delay. That wave of depolarization gets spread down the bundle of His, down the septum to the apex of the ventricles, and then the wave of depolarization spreads up through the Purkinje fibers, through the walls of the ventricles, causing them to contract from the apex, from the bottom point upwards. So the QRS complex represents the electrical charge that passes through the ventricle walls, causing ventricular systole. So this is a very, very tall spike in millivolts in voltage, because we know the ventricles are significantly bigger than the atria, and the muscle wall is a lot thicker. So in order for the ventricle to contract, there has to be a big voltage passed across the ventricle walls to allow that really high build-up of pressure, ventricular pressure. So we can call the QRS complex number 2 ventricular depolarization. Okay, and we know when the ventricle walls depolarize, it causes the muscle to contract from the bottom upwards. So the QRS complex represents ventricular systole. Okay. Now, we know once the ventricle has contracted, over time, it will then start to relax diastole. So the T wave represents a repolarization of the ventricle walls, which allows the cardiac muscle of the ventricle wall to relax. So we can say the T wave represents ventricular repolarization, which allows the ventricle to undergo diastole or relaxation. Now you can see the T wave is actually a bit longer in seconds than the P wave number 1, and that's because repolarization of the ventricle wall takes a little bit longer compared to the depolarization of the walls of the atria and also the ventricles. Now, if we look at a single trace, ECG trace, we can actually see that these peaks are repeated at regular intervals, and this ECG trace shows the heartbeat over time. So this is a nice regular healthy heartbeat. Now the way to work out how many beats per minute is to take any points on a single ECG trace, maybe the peak of the QRS complex here on the left, and then work out the time it takes for that QRS peak to be repeated, and it will again be repeated at regular intervals like this. So if the time between the QRS spike, okay, or the R point is say 1 second, then in 1 minute the heart must beat 60 times, because this represents the time between a single heartbeat and the next one. Now if this was, for example, not 1 second but say 0.8 seconds here, then the heartbeat would be 60 seconds divided by 0.8 gives us 75 beats per minute. So if we know the distance in time between one part of the ECG and the next ECG trace, we can actually work out the rate of beating of the heart. Now, when you actually look at this on the ECG graph paper, you'll see little squares. Now, each little square represents 0.04 seconds on the x-axis, and it represents 0.1 millivolts on the y-axis. So if we look at the ECG trace again, we can then start to work out how long each of these depolarization or repolarization events takes place, how long they take to occur. So the P wave, for example, here, it starts at that point and it ends here. So it's just over 2 squares wide. So it must just be around about 0.08 seconds, probably nearer 0.09 seconds. Now the T wave, representing ventricular repolarization is 1, 2, 3, 4, nearly 5 small squares wide. So 5 times 0.04 gives us 0.2 seconds. So we can see the T wave, the repolarization of the ventricle walls, actually takes a bit longer than the initial depolarization, which is represented by the QRS complex here. And it's also shorter than atrial depolarization. So we can now link the ECG trace with the cardiac cycle and control of the heartbeat through the SAN. Now, the sinoatrial node is a specialized area of cardiac fibers that originate the wave of depolarization. So we call this the SA or sinoatrial node. Now, the wave of depolarization spreads across both atria, so the right atrium and the left atrium, which causes depolarization, which causes contraction of the atrial walls. So we know atrial depolarization and contraction is related to the P wave. We know the wave of depolarization then gets picked up by another specialized area of cardiac fibers called the atrioventricular node, or the AVN. Now here there's actually a 0.1 second delay, and that's to allow both atria to finish contracting and squeeze all their blood down to fill up the nice relaxed ventricles, because there's no point in the ventricles contracting unless they're full with blood to make the heartbeat more efficient. If they did start to contract without being full of blood, then the heart would have to work harder, it would have to beat more to get the same volume of blood around both the pulmonary and the systemic circulation. Now, the septum that separates the atrium with the ventricle up here, okay, this tissue has connective tissue in it, and we know connective tissue does not conduct electrical charge, so the wave of depolarization cannot spread from the atrium directly down the ventricle wall. Now, the AVN passes the wave of depolarization to the bundle of His, and we know there's 2 branches to the bundle of His. It passes down the septum between the 2 ventricles, and it then splits into Purkinje fibers that pass up the walls of the ventricles. So the wave of depolarization spreads very, very fast down the septum, down the bundle of His, up the walls of the ventricles through the Purkinje fibers. And that causes the ventricles to depolarize from the bottom up and therefore contract from the bottom up. So the QRS complex, if that's Q, R at the top and S back down here, QRS complex, that corresponds to ventricular depolarization and ventricular contraction. Now, you can't actually see the atrial repolarization here on the ECG trace, because it's actually it has the QRS complex on top of it, so that kind of masks the atrial repolarization. But we know as the ventricle is starting to contract, the atria have actually already started to relax and gone into diastole. So that's the reason you can't actually see atrial repolarization, because it's kind of masked by this QRS complex, which is a big spike in voltage across the ventricle walls. So we can now start to look at abnormal ECG traces. Now, the picture here at the top of the slide is a regular ECG trace. It's a normal healthy heartbeat. The QRS complex we can see is at regular intervals. But if we look at a condition called atrial fibrillation, we can start to see that the QRS complex are not as regular, and there's actually more of them. So if we start with this one here, we can see that the next one occurs over a short space of time, as does the next one. The jump from the third QRS to the fourth one, it takes a little bit longer. So it's not regulated, it's irregular, and here the heart is beating much more faster or much more quickly than the normal heartbeat. So as we normally might get, say, 72 beats per minute in a healthy person, someone with atrial fibrillation can beat anywhere between 300 to 600 beats per minute. Now, if we look at the picture of the heart underneath, we can start to draw on why this occurs. So we know the SAN node is in the right atrium wall, and it should pass the wave of depolarization across both atria in a nice coordinated manner. But in atrial fibrillation, there's a haphazard passing of the electrical impulse through the atrial muscle wall. So it's not a coordinated wave of depolarization. And this means that contraction of the atrial walls is not highly regulated and organized. So it's very inefficient, and not all of the blood gets squeezed out of the atria down into the ventricles. So some of the blood can remain in the atria, and sometimes it does actually start to clot within the atria chamber. So if we look at the normal heartbeat at the top, we can actually see the normal P waves. Now the P wave we know corresponds to atrial depolarization and therefore atrial contraction or systole. And if you look underneath at the ECG trace for atrial fibrillation, there isn't actually a P wave, or it's not very obvious. And that's because it's the wave of depolarization is not regulated. So we can't see a clear P wave. Now, because the ventricles don't fill up with blood, as they should do, it means the heart has to beat a lot faster to get an equivalent amount of blood around both the pulmonary and the systemic circulations. So the heartbeat is an irregular heartbeat. There's no P wave. There's no coordinated wave of depolarization from the SAN. Now, if we look at the QRS trace here, we're going to start to look at a condition called myocardial infarction or heart attack. Now, we know atherosclerosis, if that occurs in the coronary arteries, then it can block the movement of blood to the cardiac tissue of the heart. So if that cardiac tissue does not receive enough oxygen and glucose, it can't respire, and over time it will die. So the death of cardiac tissue is called infarction. And you can see on the picture here that this cardiac tissue has actually started to die off because of the blockage of that coronary artery that would normally supply it with oxygen and glucose. Now, ischemia is a lack of blood flow, oxygenated blood flow to this heart tissue. So ischemic or ischemia can refer to a lack of the appropriate oxygen or glucose that's needed for the healthy tissue. Now, if we look at the picture on the bottom of the slide, you can see that the darker red is the damaged or dead necrotic tissue. Now, because the wave of depolarization can't pass up through the ventricle walls as easily, because we know dead tissue does not conduct electrical impulses, the wave of depolarization has to kind of go around the necrotic or dead cardiac tissue. And this causes the ECG trace to look slightly different. So the ST segment, so from here to the start of the T wave, quite often it gets elevated, and we can see an elevated ST segment as part of the ECG trace. And that could be characteristic of a myocardial infarction. The ECG trace will change over time according to how near or how far away from the heart attack the trace is actually generated. But an elevated ST segment could indicate that there's damage to the heart tissue, and the wave of depolarization can't spread up through the ventricle walls as easily, and so there's an elongation of this portion of the ECG trace.